If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, HEP in the UK. In today's episode, we'll look at the NICE updates published in December 2025, focusing on what is relevant in primary care only. And this time, we have just one updated guideline that is relevant to us in general practice, the guideline on when to suspect maltreatment in children. Right, let's jump into it. In December 2025, NICE updated the guideline child maltreatment, when to suspect maltreatment in under 18s. The core change in this update is the addition of a definition of the term independently mobile. Before this update, the NICE guideline used the term independently mobile in several key recommendations, but did not define what that term meant. We were expected to interpret it based on our clinical judgment. This led to variation in practice, particularly when assessing injuries such as bruises, lacerations, and abrasions. Different clinicians could reasonably reach different conclusions about whether a child met this threshold, even when looking at the same clinical picture. The term was sometimes difficult to interpret. What about rolling, crawling, bottom shuffling, etc.? The definition has been developed using a formal consensus process. A child should be considered independently mobile if they can do any of the following: crawl, bottom shuffle, pull themselves up into a standing position using an object, for example furniture, move into a standing position unaided, cruise, that is, move from place to place holding onto an object, for example furniture, climb, for example onto furniture or stairs, walk using a push-along walker, or walk unaided. Children under 12 weeks of age typically lack the muscle strength, coordination, and neurological maturity needed for independent mobility. However, age alone should not be used to determine whether a child is independently mobile. This definition has now been added in 3 areas, specifically in recommendations on bruising and petechia, lacerations, abrasions and scars, and burns or scald injuries. Compared with the previous version, the key difference is clarity, not threshold. The level of concern for injuries has not been raised or lowered. Instead, we now have a shared understanding of which children fall into the higher risk group when assessing unexplained or concerning injuries. Otherwise, no other major changes were made to the recommendations on child abuse and neglect. Right, this is the end of the update itself. And as we have a short episode today, let's now look at a brief summary of this guideline. And the first thing to say is that the aim of the guideline is to help us recognize features that should raise concern and prompt further safeguarding action. We are not expected to confirm abuse, but to recognize the risks and act accordingly. Let's now briefly review some of the examples of when to suspect or consider maltreatment. These are situations that may need urgent safeguarding action or discussion with local safeguarding leads. We should suspect maltreatment when there are injuries with no explanation or an explanation that does not fit, especially bruising, cuts, abrasions, burns or scalds in a child who is not independently mobile. Bruises with clear shapes such as hands, grips or ligatures, burns or scalds with clear patterns or signs of forced immersion, multiple injuries or injuries of different ages, injuries that are symmetrical or in unusual locations, and injuries that are in areas normally covered by clothing. We should also suspect maltreatment with serious injuries without adequate trauma, including fractures, especially multiple fractures or rib fractures in infants, fractures of different ages, intracranial injury without a major accidental cause, retinal hemorrhages or unexplained eye injuries, and spinal, abdominal or chest injuries that are unexplained, even if there are no external signs. Additionally, we should suspect sexual abuse when there are clear indicators including genital, anal or perianal injury without an accidental cause, and pregnancy in a child under 13 years, which is a strong indicator of sexual abuse. Pregnancy in a 13 to 15-year-old should prompt assessment for sexual abuse. We should suspect neglect when there are strong indicators such as repeated failure to provide basic care, food, warmth or safety, and failure to seek medical help that puts the child at risk. We should also consider possible neglect if there is, for example, poor hygiene or inappropriate clothing, an unsafe home environment, missed immunizations or health reviews, and severe or ongoing infestations. And we should be concerned if parents or carers fail to give essential medication, repeatedly miss important appointments, or do not seek medical help when appropriate. Also, poor school attendance without a clear reason and repeated or unusual healthcare attendances, especially across multiple services, should also raise concern. Additionally, we should consider fabricated or induced illness when reported symptoms do not match clinical findings, and when symptoms only occur in the presence of carers and investigations are repeatedly normal. We should consider maltreatment when there are behavioral or emotional concerns, such as sudden changes in behavior, extreme fear, withdrawal or aggression, self-harm or eating problems without a clear cause, sexualized behavior that is not age-appropriate, repeated self-harm, and ongoing wetting or soiling not explained by a medical condition. We should also consider maltreatment when there are concerning parent-child interactions, including hostility, rejection, or lack of emotional warmth, unrealistic expectations of the child, and refusal to allow the child to speak alone when appropriate. Running away from home or living away from caregivers without agreement should also raise concern. And to end, let's remember that the key messages for us are that we should follow safeguarding procedures and seek advice early. A pattern over time is often more important than a single event, and we should trust our professional judgment and discuss concerns if we are unsure. Remember that this is not an exhaustive list, but a summary of some relevant cases to be aware of. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guideline. You must always use your clinical judgment. Thank you for listening, and goodbye.